Kindly welcome in so that we can start. It's 9 o'clock on the dot, and we know that time is of the essence. Yeah. So, distinguished guests, speakers, all the attendees, both physically and online, good morning. My name is Nyamiobo Joseph. I'm the Master of Ceremony for the day, and I'd like to welcome you to our second symposium at Chiromo Hospital Group with the theme of Emerging Issues and Frontiers in Mental Health. Since it's about emerging issues, I had to consult AI on how to be a Master of Ceremony. And AI told me I had to start with an icebreaker of a joke. However, I had prepared a joke on the weather, and it looks warmer than I thought. I also prepared something on paranoia, but I can see you're all watching me, so I won't say something about that. I would like to acknowledge the presence of the committee that was involved in preparing and getting ready for this event today, with the convener, Dr. Neil Horn. Maybe you can kindly... I'd also like to acknowledge the presence of our sponsors, Johnson & Johnson, Ministry of Health, Cosmos, Novesi, Square Pharmaceuticals, Synamed, MSN, MeLife, and Sun Pharma. We also would like to maybe communicate about housekeeping for any issues with your washroom. Just at the far end, you can turn left. You will see the washrooms on the end. With that, and with no further ado, I'd like to welcome you to today's event. And I'd like by starting by welcoming the Group CEO, Dr. Vincent Hongo. Welcome.
Thank you, Dr. Joseph. To our chairman and the only chairman I've known for the last 2 decades, the convener, Dr. Neil Horn, and the chair of the scientific and organizing committee that has been acknowledged here, to Professor Atuole, Professor Madai, our teachers sitting here, my colleagues, friends, mental health actors, Hamjambo. To our global partners, good morning. It is my privilege to invite you to Chiromo Hospital Group. As Dr. Joseph has said, I serve as a team leader, a leader of a psychiatric center of excellence. Today, as is said, the convener and the organizing committee has arranged this important event, Emerging Issues and Frontiers in Mental Health. This is the second edition, 2026, and it is coming at a time that is so important to us in the mental health care space. We understand the burden on one end, and we understand what is required to address that increasing burden. Good people, for us to move this course from the periphery, from the margins to the center, it must take effort. That effort requires you who is sitting here today and many watching on the global platform to push the mental health agenda to the center of everything. Mainstreaming mental health matters policy and everything else has taken the hands of many. When I look here, Chair, I see those whose hands have been placed on the pulse to ensure that mental health is mainstreamed and it is at the center of everything. Why that? We know the impact of mental illness. Globally, we have seen across the world the increasing disability rates. We have seen the social disruption that comes when mental health care needs are not adequately addressed. Good people, we have seen that this burden from all the global operators, it requires significant effort. It requires dedicated, adequate resources that will address this burden. As Dr. Joseph has joked this morning, AI and data are becoming central in addressing this matter. I am happy to report that at CHG, we have not been left behind in that regard. Going forward, my good people, emerging issues in the mental health care landscape, the new frontiers are opening in the mental health care landscape will require data-driven decision-making systems. The data-driven decision-making systems will be developed by you and all of us who are attending this second symposium organized by this team. I'll let you know that CHG as a center of psychiatric excellence has not been left behind. She allowed me to floss about some of the initiatives that we've undertaken in this regard to work in sync with these realities. The first, and importantly, is that our nearly 30 years of existence has been off the digital space. We have been digitizing our extant clinical data, and Professor Atwoli will be happy to note that it is being organized and arranged in a researchable platform that will impact decisions. This year, we have successfully rolled out a co-created system across our entire network. This system, as you will come to know for those who will interact with it, is created by you, is created by us to impact the mental health care landscape. The data that has been off this platform is being digitized. The 30 years, nearly 30 years of clinical rich data is being organized to impact policy, to impact clinical outcomes. Sitting before me here, Chair, is a young girl, my friend and my colleague, whom in my cognitive space I consider Professor Lynette Ongeri. Let's clap for Professor Lynette Ongeri. Professor Lynette Ongeri and Professor, a very young girl called Mariciana Onono, have been dedicated in this regard. They have engineered this system to speak to these clinical and social causes that we are talking about here today. Professor Lynette Ongeri, you'll get to know that very soon. The dashboards of clinicians who will interact with this system will speak to you. It will speak in a very dynamic way how the clinical pathways you engage impact on the clinical course and progress of the patients that you handle. Good people, you'll be happy to note that on your dashboards, you'll be able to see, one, your average length of stay. We want to show that psychiatry works and psychiatry makes lives to be functional in the society. You'll be able to see how long you treated this client, and you'll be able to see the rate of readmission for any client if ever you treated. you'll be able to see the interval between the discharge period and, if any, readmission period. The clinical metrics that have been built onto that platform have not been by chance. It has been a very deliberate initiative, board level. Good people, you'll be happy to know that the board of directors led by my mentor, Professor Frank Njenga, dedicated a data scientist, Professor Ongeri, Professor Marisiana, recommended a qualified data scientist with IT skills to lead this process. We are happy that we will not be left behind. We will shape the future of psychiatry. We will continue to focus into the horizon, clearly see what are the emerging issues on the horizon, and address them appropriately. Chair number 2 is to note that as a team, we have not been left behind in community engagements. You taught me as my mentor that evidence-based medicine is real. For those who can see, Shitera, use this camera. For those who can see, you can see Professor Njenga left for Atlanta and he came back and he told me, Daktari, we need to impact the community and impact community holistically. Today we are proud to state that about a month ago, in a nationally, regionally televised platform, the Archbishop of the Anglican Church did launch this handbook for the faith-based leaders. Professor Njenga has just returned from a coastal tour of duty, and he told me that the Muslim faith, Professor Lynette Ongeri, has not been left behind. That you will soon, together with Dr. Chibanzi, an actor in the coastal region, develop a handbook for the Muslim faith-based leaders. Let us clap for them, good people. I must also tell you that going forward, the clinical outcomes will not be left to disappear at our gates on discharge. The clinical team, led by our corporate psychiatrist, our chief corporate psychiatrist, Dr. Charlene Gumbo, is sitting right at the back there. I can see the team sitting across in this room. And the clinical services managing the nursing team have strategically positioned a strategic quality management integrated follow-up program. This will monitor the care beyond our gates. At admission in this group, a client is attached to a clinician, and that clinician remains a partner beyond our gates. Our follow-up program is very robust, and it is what ensures that they remain functional in the society. The 30-year service has largely been face-to-face. Good people, led by our digitally savvy professor and chairman Njenga, they have directed me and the entire team to onboard this service onto the virtual platform. Going forward, access to this evidence-based, dignified, quality mental health care service will not be limited to our geographic locations. We are onboarding this solid legacy service onto the virtual platform that will be accessible beyond our geographic locations. It will be at your convenience, and this is in sync with the emerging frontiers and issues in the mental health care landscape. Lastly, Chair, financing mental health care will be nuclear going forward. All the initiatives that we've concretized and distilled to impact the lives of people in this space will be relevant if they are not adequately resourced. We've had the UHC, we've had SHA in this part of the world, and many other healthcare financing initiatives from the global to regional to national platforms. WHO assemblies, when they sit, they insist that that resource must be adequate, reliable, dependable, and scalable to support this rising need. The data that we will sit together to develop is what will inform the level to which healthcare financing, mental health care financing will be resourced. We depend on you to be able to push mental health care financing that has largely been under-resourced, under-financing. The levels we talk about less than 1% nationally, to be able to address it. We are showing our partners, we are showing the actors in the insurance, in the HR, in the finance space, that mental health care works. A schizophrenic, an alcoholic, any bipolar client can be treated. Dr. Kevin, I can't see his face, a young registrar, but Chair, you remember when we discussed, we'll look into the figures in the payouts for insurance companies. And good people, let me tell you, when we look at it with our partners, we know that it is cheaper on an average daily average discharge bill to treat a psychiatric illness compared to malaria. Please clap for yourselves. We have shown in this facility using facts that the average daily discharge bill for treating a schizophrenic, the top 10 diagnosis in this center, is cheaper, almost 1.5 times cheaper than treating malaria at the same level. We need you. We cannot do this as an institution. Good people, these initiatives, the very brief ones I've highlighted, are not for institutional branding. The initiatives I've highlighted are structural initiatives that shape the future of psychiatry. We are adjusting our strategic lenses to be able to clearly focus into the future and address those needs as they emerge. As you sit here as a delegate, you are not just sitting for a dialogue. You are sitting to shape lives. You are sitting to shape the future of psychiatry. It is my honorable pleasure to welcome you to this facility and invite my mentor, Professor Frank Njenga, to give us his opening remarks. Thank you very much and enjoy your symposium.
By any definition, that's a commercial. All right, so I think we just leave that one as it is and proceed with the science of today. I didn't check on AI what opening remarks mean. That's because I know what it is. I was reflecting on why we need to meet in a forum such as this one. And it's clear to me over the last maybe 6 years since this branch opened that there are gaps in the way we do or conduct the business of mental health in this part of the world, mainly because we have been unable, for reasons that are not clear, to change the fundamentals of our practice, in the sense that we are by and large very reactive in the way that we do our business. And the Chiromo Hospital Group, I think, has committed itself to being the custodians of thought around the future and where it is that we think we should be going. So today is a forum for us not to look back at what causes anemia in pregnancy amongst people of Korogosho, but to look at a number of issues that I think are what the future looks like. Do we have any slides, or can I just continue saying what I want to say? So the question of the issues are as illustrated in a moment in the next slide. One of the big issues is 1 billion people who live in Africa, called the youth. Now, this number of 1 billion people under the age of 35 are either an opportunity or a serious problem for us. And thinking about mental health and the issues that go around the mental health issues around young people, I think that's one of the things that we'll be discussing in a session later in the day. And then there are their parents and grandparents, which is now ourselves. The two things we have that they don't have. One is advanced age, two is wisdom, and thirdly, the fact that we have all the money that is required. Now, that sounds like it's funny, but it's very important because we need the young people, and the young people need us. And I feel there is a tension between the young and the old in terms of the methods of communication. They think they can talk up to us. We know that we have wisdom and can teach them a lot of things. But I think that there is inadequate communication between these two very important groups of people. And I would like to hear a little bit in the course of today of a conversation around how we can improve that communication. And then there are very serious geographical issues that I'd like to hear one or two things about in the course of today, which is the whole subject of refugees and migration. We had recently, I think it was class, Dr. Gumbo, you remember, a look at what happens to us Africans as we travel to Spain, to Italy, to America, to other parts of the world, and how our mental health challenges are very different from the mental health challenges of those native populations. And I would like to share a little bit from those who know better how we are going to help our brothers and sisters who go out there to help the Americans and the Brits manage their healthcare systems. This morning, there's a very loud, literally loud conflict going on in the Middle East. But we have our own forgotten conflict in the DRC, in Sudan, in West Africa and other parts of the world. And we understand that these are grounds that are preparing for very serious challenges, including transgenerational transmission of trauma. So these are things that we don't read very often in our textbooks, but these are serious challenges that this group here ought to be thinking about. Dr. Joseph was unable to give his prepared joke because of climate change. Now, one of the big problems that we are coming across here is the whole issue of climate change. And it doesn't matter whether climate change is man-made or not. The reality is that it is there, and it's a reality. And it's also a reality that is impacting our mental health and that of the future generations. I think Lukoy in 2022 in the British Journal International, you wrote an incredible piece of writing on the mental health impact of climate change. This is not something we teach Prof. Mathai every day in our, because it's not in the curriculum. But I think the reality is that whether it's in the curriculum or not, climate change has adequate importance and significance to the way we conduct mental health issues for us to take it extremely seriously. And then there are other things that are almost taboo for us to talk about as doctors. Many years ago, I tried to suggest, without success, that a doctor is incomplete if he's not conscious of what is going on around him. Matters of governance, matters of politics, matters of democracy, social justice. But now the science around how important these issues are to the mental health, particularly of young people, is it's clear, incontrovertible. And I think a forum such as this one is convened for us to be able to talk without fear about social justice, among other things. I had a sneak preview on the next slide. He doesn't know I did, but I had a sneak preview of Professor Tuole's presentation. I was looking like this and I saw. So the next slide is not important because I know he's going to tell us about precision psychiatry and other issues like that. I think, Lukoy, you're also going to tell us about artificial intelligence. Very good, so I skipped that one. Next, I want to talk about the death of a DSM classification system, because DSM is about to die, and it will have to die, because the system of classifying diseases by symptom is completely ridiculous and retrospective. Are you going to touch on that, Lukoy? Yeah, because you know, even now, and even for old people like myself, we recognize the reality that the future classification systems will be based on biomarkers. Depression now is conceived as an inflammatory process, and that's just the way it is. We know that. And I think it's time we started preparing ourselves for the day that inevitably people will have medication prescribed to them based on genetic profiling, not on this guesswork that we are doing currently. Next slide. And then there are other big issues, some of which emanate from our experience of COVID-19. And this sounds lazy or ridiculous, but what is a workplace? When I say I have gone to work, does that mean I have come out of bed and sat on my desk that is next to my bed? Does it mean I have commuted for 3 hours to a little box that is called the office? What is the workplace and what is work? Then there are other important issues which we have discussed. I think we discussed this in Mombasa. I think it's an important issue. I hope, Lukoy, you will touch on this one. Are we going to be replaced by artificial intelligence? And if you are, what do we then do? If artificial intelligence is going to help us, in what way is it going to help us? I think this is a conversation we need to have. Recently, and I'm now about done, the European Union has come out with very clear policies and responsibilities of what they call the toxic work environment. How much do we discuss toxic work environment? When sister shouts at the orderly in the ward and makes them feel little, is that the creation of a toxic work environment? When Dr. Hongo speaks loudly at Mr. So-and-so, what are the legal consequences of that? When I treat a younger doctor like Dr. Joseph without respect, what are his rights? What are his? These are things that will impact his mental health. These are things that, and we have seen this in the classroom, in clinical practice, particularly from our brothers in surgery. Sorry. Sorry. These are taboo subjects, but I think these are subjects that are emerging and affect How much are we expected to accommodate neurodiversity in our hospitals? Do we exclude them? How do we include them? Do they exist? Do they appear in our HR manuals? If they do, what accommodation do we give them? Why do we give them? Neurodiversity is an issue that we as psychiatrists and other mental health workers are very familiar with. What are we, every day we are asked to write little notes or to accommodate a student who has to do an examination. We have workers, I think this week we had workers to accommodate in this sort of way, and so on. Now, I've told you that we have 1 billion young people in this continent. This is the next slide, I don't know where we are. Yeah, that's right. On the second bullet point, I am here suggesting that what happened when we were colonized as a continent around 1885 in wherever this fellow sat, and divided Africa into little pieces of cake. That process is about to reverse. I actually suggest that we should start preparing for the day that we shall colonize. And I think we shall start with Italy, go to Greece, go to Portugal, go to Germany, and actually divide those countries, and we will dominate them, not in the way that they dominate. Neil, why do you find that funny? Well, all right, perhaps finally we'll get to Greenland. What I'm saying is that, truthfully, we are a young, vibrant, futuristic group of men and women who are a natural resource for the globe. And if we are going to accept the responsibility of managing the affairs of this globe, we must think about it today and not wait until tomorrow. We've talked about climate change, so that is done. And the last slide, and again, this is the only forum, and I'm sure KPA will accept the responsibility to our next meeting in the exotic city of Diani. Is that where we're going? Yes? To start thinking about issues that we don't put on the table as often as we could. Urban planning and mental health. Who knows anything about urban planning and mental health? Utility of open spaces in the promotion of mental health. We had a grand round recently about the bacteria in the gut and how the bacteria in the gut produce serotonin and make us feel good. I went to the American Psychiatric Association meeting with some of our colleagues who are here, and the only thing they were talking about is how much sleep you should have. Boring, yes. How much food you shouldn't eat. Boring. And how much movement you should have. I mean, these are the things that we think are things that belong to second and third year medical school, but these are the real issues around the promotion of mental health. And finally, and Lynette, I speak to you on this one. If my numbers are right, yes, there are 4 people who will die by suicide in Kenya today. Yes, a total of 1,460 died last year, an extreme underestimate by any standard. The majority of them are the very people we shall depend on to go and colonize the Western world. Really, these are the key issues that I think this meeting has been called to deliberate on. Ladies and gentlemen, allow me to say that it gives me the greatest possible pleasure to declare. This is, Joseph, this is the job of welcoming speech. Yeah? It gives me the greatest possible pleasure to welcome you and declare this meeting officially open. I feel like I'm Mheshimiwa now.
Thank you very much, Chair. Thank you very much, CEO. I feel like a small man when I talk after them, so I won't talk more after this. So it's my pleasure to welcome the next step of our symposium, which will be a session on artificial intelligence, which we will be moderated by Gathoni Mbugua, who is one of our hospital psychologists and head of digital team. Welcome, Gathoni.
Good morning, everyone. My name is Gathoni Mbugua, as you've heard. I'm a senior clinical psychologist, and I'm the head of digital relations at Chiromo Hospital Group. Having the honors of starting the first session on AI, allow me to extend sincere appreciation to our convener, Dr. Neil Horn, for your visionary leadership in bringing this symposium together. And many thanks to our CEO, Dr. Vincent Hongo, for guiding this team. And special thanks to our group chairman, Professor Frank Njenga, for the strategic leadership that makes conversations like this possible. So today we gather under a powerful theme, which is Emerging Frontiers in Mental Health. And indeed, we are at the frontier moment. Mental health is no longer confined in clinics or textbooks. It is being reshaped by technology, global realities, and now AI, artificial intelligence. And AI is not only transforming how we diagnose or how we treat, it is transforming how we think, how we learn, how we connect, and how we make the decisions. So the question before us today is not simply what AI can do. It is what should it do and who decides. This session brings together distinguished voices to explore AI in mental health from ethical, clinical, and academic perspectives. We are not here to fear technology. We are here to question it, to shape it, and to ensure that as we innovate, we do not lose the human heart of care. And with that, let us begin. It is my distinct honor to introduce our keynote speaker this morning, Professor Lukoe Atwoli. Let's give him a round of applause. Professor Atwoli is a professor of psychiatry and the Dean of Medical College, East Africa at Aga Khan University, where he also serves as a deputy of Brain and Mind Institute, professor of psychiatry and mental health at the University of Cape Town, and the chair of the board of Mathare National Teaching and Referral Hospital, a globally respected scholar and leader. He is an international distinguished fellow of the American Psychiatric Association, among other prestigious international and national honors. Professor Lukoe Atwoli, please come. Let's give him a round of applause.
Thank you, Gathoni, for a very kind introduction. And good morning, everyone. My task is a difficult one of discussing a topic that is current. But again, it's an easy one because the topic is really easy for most of the people who will be hearing about it. If you can have the next slide, please. And the next slide. So my task is really to convince you that what we call mental health today and what we call neurology today, all of it is going to collapse into something that is brain health and about what the brain does. And this is going to be facilitated by artificial intelligence. That's the first thing that I think we're going to agree. And this is because historically, neurology emerged because people saw direct things that happen to the brain and their impact. And then they created a field to deal with that. And psychiatry arose from how people behave and the things that people do when they behave in ways that society thinks are abnormal, and how to try and correct that. So that's how they grew. But the more we learn, the more we realize that all these are products of the same processes that are happening in the brain. And so neurologists and psychiatrists are finding that they must engage together, whether it's in the patient's world of thinking and behavior, or in something that is happening directly to the brain. We must operate in the same field. So we are going to have to agree that psychiatry is a nonsense field, that neurology is a nonsense field, that they are the same thing. They're coming out of what is happening in the brain. And the second thing that I want to put out there is that this field, which I'm going to call neuropsychiatry, is the template upon which artificial intelligence is built. So maybe let's move to the next slide, if that's possible. So in order to understand brain function, scientists started designing artificial models in the middle of the last century, in the 1940s, 1950s, trying to imagine how you can compute how a brain works. And so they created something called perceptrons, which are really programs that are called linear classifiers that were invented in 1943. So artificial intelligence is not a new thing, and it's not something that has just started in the 2000s. It's something that started in 1943. I think this is showing that's not. And this became the basic building blocks for machine learning, which is an important subset of what is now called artificial intelligence. And therefore, AI mimics human brain function in two ways. One is that using AI, we are able to build neural networks that mimic brain structure to solve complex problems. And I'll show you how that happens. And they also mimic human intelligence. So for instance, reading text, interpreting speech, classifying things, and so on and so forth. So artificial intelligence is a field of computing where programs are developed that have the ability to learn and reason like humans. So when you see the output, you think, or it looks like this thing has thought like a human being. And then there's a subset of AI that is known as machine learning, which is a method of developing algorithms that learn without being explicitly programmed. So usually you'll get into a computer program and you'll tell it, like when you have a calculator, you say, 2 times 2, and then you wait for the output, and then you do something with that, and then you do something with that. But in artificial intelligence, you would tell it what you really want as the outcome. And then it processes data and gives you that outcome without explicitly telling it each stage what should be happening. And then deep learning is a subset of this machine learning that involves development of algorithms that are known as artificial neural networks that adapt and learn from vast amounts of data. So this is the ecosystem within which artificial intelligence happens. And on the next slide, I'm going to show you how this attempts to replicate what is happening in the brain. And you will see on the right, you'll see how a neuron functions and how a neuron looks like. So there are inputs that come into a neuron, and then there is what happens in between after you receive the inputs, and then there is the output. So you touch fire, your muscles are activated, and your hand moves away. That is the output. So in the same way, with artificial intelligence on the left, what you would see is that there are inputs which are entered into the system. Each input is weighted based on its importance, and the same way the brain does. Like, so if you feel pressure, is not as important as pain. And so those weights are calculated based on the importance of the inputs. And then there's a transfer function. The transfer function is what the threshold that determines what should happen after you receive this number of inputs. And then there is the activation function, which determines what happens after that. So what's the effect of receiving these inputs, and so on and so forth. So that's the simplest, the basic building block of AI. That's the perceptron. That is the thing upon which AI is built. And so moving from that basic building block, on the next slide, you will see you can have thousands, you can have tens of thousands, you can have hundreds of thousands of those building blocks built into a system that then does multiple processes to give certain outputs. And that's what we would call then an artificial neural network, because you have multiple of those perceptrons or those neurons that are working together to give you certain outputs. And in the middle, what you see is the hidden layer. And it is hidden only because it will take huge amounts of time for a human to go through each and every one of those processes and understand what's happening. That's the only reason it is hidden. But it's not really hidden, because if you had millions of years, you could actually go through those things and see what is happening in each of those places. But we don't have millions of years, and so those layers are hidden from us. But broken down, if you take each and every one of them, it's a very simple process. There are inputs which are weighted. There's a process that happens to those inputs, and then there's an output. So that's the simplest way of understanding AI. So what is AI? What is AI? You have to understand it at the most basic level, that these are programs that use huge volumes of data to classify things based on similarity and differences, to predict future outcomes based on previously collected data, and to recommend interventions based on previous outcomes. That's the simplest way of understanding what AI is in whatever field that you go into, whether it is traffic, whether it is security, whether it is mental health, whether it is chronic disease management, and so on. It classifies things based on similarity and differences, so it clusters things. It predicts future outcomes based on previous experience, so previous data, and it recommends interventions based on what we have done that was successful. That's the most basic way of understanding this. It is designed to mimic human thinking, speech, appearance, movements, and so on. So you can create a robot, and that robot will behave based on those three things. One is to classify, to predict the future, and to recommend interventions. So if you have a robot that is designed to clean your house, it will clean your house based on how other humans have been cleaning the house, and based on how you want the house to look like after it has been cleaned, and so on and so forth. It is able to perform calculations with huge amounts of data at incredible speeds. That is the biggest difference. Like, it does these things at scale, which we would need a longer time to do. So it's good at number crunching and data processing. And then it helps deliver on the things we humans want to be done. So it doesn't do things out of its own agency. It does things that we want done. We want a clean room. We want not to be depressed. We want to sleep well. We want to eat good food, and so on. So it does things to ensure that we meet those very human needs in ways that will take more time and resources if solely done by us. What AI is not, and when the screen shows up, you'll see what I'm talking about. So what AI is not, the I is fake. AI is not intelligent. So it's not intelligent in the way that we understand intelligence. It is based on algorithms that are built by humans with a lot of human help, feeds off of mountains of data that we generate and create in order to classify things, to predict things, and to make recommendations given based on given data sets. When you talk about training an AI model, it involves feeding it with that data, looking at the outputs that it gives, and telling it this is 100% wrong, or this is close to right, or this is in the middle, so we need to move this way or this other way. So it is humans telling it that you're stupid or you're doing the right thing. So that's what training means. There's a human in the loop. There's always a human saying, hey, this output is incorrect. And you know this because there are cases right now about Kenyans, and Kenyans are perhaps maybe the most intelligent humans for many reasons. But one of the reasons is that the Meta, this company that owns Facebook, uses Kenyans here in Nairobi to look at the things you guys do on Facebook and to tell it whether those things are the things that should be done or not. So they train the algorithm that Meta uses to show you the things it shows you. Because everybody who is on Facebook sees different things on their timelines. And there are Kenyans behind that who look and say, yeah, if you're in Brazil, these are the things that make sense for you. If you're in Kenya, these are the things that make sense for you, and so on. So there's always a human in that loop. AI is not sentient. AI does not know that it exists. We are the ones who know that it exists. The thing doesn't know that it exists. It's a program. It's a series of calculations that get input, process it in a way that we tell it to process it, and gives an output based on those processes. All right? So it doesn't know it exists. It is designed to behave in a manner that is recognizable to humans, and learning is about tweaking those algorithms. And it is tweaked in a very human way to meet very human needs. And there's a benefit in that, and there's a danger in that, because humans run the entire spectrum from 100% good to 100% evil. And all those humans are involved in programming these AI algorithms. AI is not autonomous, based on what I have said. It is not autonomous. It doesn't sit down and decide, I am going to do this tomorrow, I'm going to do this, and so on. It does what we tell it to do. And so therein lies the benefit and the risk. And that's why I wanted to emphasize that. So if you go to the next slide, so basically this is a repetition of what I have just said. In this field that I'm saying is going to come up, which is combining neurology, psychiatry, and so on into brain health, or whatever we're going to call it, AI will play a huge role in developing the diagnosis, that is classification, in predicting, meaning it tells you what your prognosis looks like, and in recommending, basically telling you what you should do when somebody shows up with certain symptoms, and so on and so forth. So it's going to play a huge role, because we can do it, but we need a million years and infinite brains to do it. So AI will do it for us. It will develop a new diagnostic system, and Dr. Frank Jenga was absolutely right when he said DSM is going to die, because it must. And it will recommend different treatments. So we are not going to be talking about antidepressants, antipsychotics, anxiolytics, and so on. We're going to be talking about different classes of treatments based on very, very, very individual presentations that patients show up in hospitals with. And we can move past the next 4 slides. To AI in automated care, previous slide, thank you. So we think that the future, what the future looks like, is that we are going to have a lot of AI in care. So today, at the hospital where I work, you can actually come in. We have a conversation between the doctor or the specialist and the patient, And then after that conversation that we have had, I will go onto the computer and I will find that conversation having been put in the way of notes. So it listens to what we are saying, and then it says, this is a history of presenting illness. It listens and says, this is now mental status examination. It listens and then it says, this is now what this guy thinks the diagnosis looks like, and so on and so forth. And it summarizes that for me. And if I want, it can look at all that conversation and say, these are the differentials from what you have had a conversation with this person. And then these are the recommended investigations. And then once I have done all those things and I put in the information in the system, it might say, these are the recommended treatments. And then I will choose from that and make a decision for my patient. And so the future, if you, yeah, the future means, because we are so connected, and right now guys are on their phones and so on and so forth. Your phones know where you are, they know how long you slept, they know how much exposure to the sun you've had, they know the pollution in this city and how much you have breathed in and so on. They know all that. Now, if that data is sent to some database that you give permission for me to access, by the time you show up to the hospital and tell me I have a headache, all I will need to do is to enter that information into the system and say, oh, today she has a headache. And then it will say, based on how she has lived her life for the past 30 years and so on, and how she slept last night and what she ate and who she was with and where she was, and that she has a headache, this is the most likely diagnosis. And so you need to do these kinds of investigations in order for you to be able to help her and so on. So that's the future. That's what it looks like, and we can't run away from it. Will AI replace Dr. Ongeri? A Dr. Ongeri who uses AI will replace Dr. Ongeri. So the specialist using AI will replace the one who doesn't. That's really the summary of this presentation. The final point I would like to make is about ethics. It's about the ethics. So if you go to the next slide, you might see some risks that are related to use of AI. So the risks are, and I think you moved very fast, and I appreciate your guidance on time. I'll take a couple of minutes. Just there's somebody there who's telling me about time, but just a couple of minutes. Okay, so I will speak to this. The first risk is patient data breaches and privacy violations. So these are things that are real. So as we use this, because it uses data, it crunches data and so on, it knows so much about you. If I have access to that, I might learn things about you that you might not want me to learn about you. So that's the first thing. The second thing is that it could be, the data I give it might be biased. So I might give it data about people who live in Britain, and then have it try and predict things that will happen in Kisumu. And that's a problem, because it will probably be wrong. The third thing is inequitable access to technology, in the sense that even in Kenya, where almost everyone has access to mobile technology and internet and so on, there is still people who do not have access to those things. And so if you design a system to develop interventions based on technology of this kind, there are people who will not have access to it. The fourth thing is the thing that we misname. We call it hallucinations for AI. But they're not really hallucinations. Hallucinations are things that you experience. What actually happens with AI is confabulation. It makes up stuff. So confabulation is making up stuff. That's what it does. And as late as last week, I went onto one of those platforms and asked them about me. And it made up stuff. I asked it, what are my top 10 publications in mental health and so on? And it made up 70% of that list. There are only 3 that it got right. Everything else was fake. And every time I kept telling, hey, but those things are fake, but nah, wait, what is that? And he said, oh, I'm so sorry, I made that up. Now, here is the real list. And in that real list, all of them were fake. And I said, hey, but again, Sasa, what is this? And he said, oh, no, I'm so sorry, I actually made that up. And then here's the actual real list. And it was all fake. So it makes up stuff, confabulation. So do not use AI for your citations, for your publications, so on. It will make up stuff and we will find out. The next risk is that over-reliance on AI can reduce clinician responsibility and skill. So people start saying, I don't need to learn how to read X-rays, because this thing will look at the X-ray and it will tell me what's in that X-ray. And it can still make mistakes. So that's a problem. And the final one is that, so all these things put together will pose risks to patient safety in hospital environments. And there are multiple guidelines on use of AI in the healthcare setting, and I would suggest that you get acquainted with them. One of them is a code developed by the National Academy of Medicine in the US, which lists the things that AI needs to do in order to be useful in the health environment. There are WHO guidelines now on use of AI in the health setting that we need to acquaint ourselves with as well. I thank you very much, and thank you for indulging me on time. I don't know if you want to take some questions or anything, but thank you very much.
Thank you so much, Professor, for that insightful presentation. And I'm sure there are so many questions that we are going to address. We will do this during the panel session. There are papers passing around. Please feel free to write some of the questions, and you can address them to the particular speaker you'd like to address. Our next speaker is Dr. Isaac Wasike, who is not here with us, but he was kind enough to send us a presentation, which we will play during the tea break. We also have with us a registrar presentation from Ethiopia, from Dr. Makonnen. Please share that on the screen. It's a 5-minute presentation, and then after that, we will go into the panel conversation.
Good morning, everybody. I'm Dr. Horn, I'm the convener, and one of the new things in this conference, one of the innovations, is our registrar competition. So we've invited registrars from all over East Africa through the East Africa Young Psychiatrists Organization to submit 5-minute presentations. And we have a panel of judges. They haven't had a briefing, I don't think, yet, so they'll have to take careful notes. And then at the end of the day, there'll be a prize giving for those who've done the best presentations. So this will be the first of those. Thank you.
Let's listen in. That's as they work on the sound. It's not? Okay. All right, I think we can go ahead and have the panel conversation. Allow me to bring back Professor Atwoli Lukoe to have a seat. And then joining us on the panel, we are going to have Professor Muthoni Maathai. And finally, on that panel, we are also going to have Dr. Rajab join us. Please give them a round of applause. Yes. We can go ahead. I would like to start with Professor Atwoli by asking you that how do you envision AI reshaping treatment, diagnosis, planning, and clinical decision making over the next decade? Yeah. Yes.
Thank you, Gathoni. As I said, so psychiatry is a special case, as I indicated, in the field in medicine, in the sense that when there's an entity called malaria, for instance, that entity shows up in a certain way. So you get a headache, you have fever, you have joint pains, and so on. Then you go to a doctor who hears these things that you have said, and then takes a sample of your blood and sends it to the laboratory, where they look for certain parasites. And then they see those parasites. And then they add the information that they have seen parasites in a person who has a headache, fever, joint pains, and so on. And they put that information together and they say, there's a very high probability that this person has malaria. And then they use previous data that says many people who have those symptoms and these parasites in their blood usually benefit from this medication. It actually relieves the symptoms, and majority of them are going to survive. Now, in psychiatry, we do not have the benefit of looking for a parasite. We only have the information. We say somebody is keeping to themselves, they have changed, their behavior has changed from baseline. They're keeping to themselves, they're not sleeping well, they're behaving abnormally based on their own behavior, and so on and so forth. And we put this information together and we say, this person probably has a depressive episode. And then we use our knowledge and say, perhaps people with these kinds of symptoms whom we classify as having a depressive episode, when they get this kind of medication and this kind of talk therapy and so on, they get better, and so on and so forth. Now, that sequence would be better crunched by a computer. A computer given that information, this information, and give more accurate output than me. Because I am using my experience of a few thousand patients. I'm using the experience of Dr. Njenga, who has taught me, and Professor Ndetei, and so on. That is all I'm using. And I'm using the capacity of my brain, which tends to forget things and tends to get formularized in a certain way. The computer doesn't have those limitations. And so AI will help us better classify the things that are happening in the brain, including those ones. It will help us to better determine what we need to do when a patient shows up in front of us, and it will help us to better explain what is likely to happen to a patient after they have shown up with us. So we can tell them, based on what we currently know, this is how you're going to live the rest of your life. We can tell them based on AI. So AI is going to be a very, very helpful and important tool in diagnosis, in treatment, and in prognosticating. Yeah.
All right, thank you so much, Professor, for that. And I think just to reemphasize, we have no need to fear it, rather integrate it. Yes.
Absolutely. I mean,
Yeah.
When typewriters showed up, there were people who used to do shorthand. There was something called shorthand. Many of you don't know anything about shorthand. Many of you have never seen shorthand. But there were people who used to go to secretarial colleges to be trained in how to write shorthand so that they can write very quickly what the boss is saying. And then they can go and translate that into a document. But they would scribble nonsense things on paper, and then that was shorthand. So when typewriters showed up, these people who were experts in shorthand were threatened, and they were so scared. They were like, oh, this thing is taking over our job, and so on and so forth. But then those shorthand experts who learned how to use a typewriter replaced shorthand experts. And then suddenly, Windows showed up, and you guys, you don't even know Windows in the early 90s. Yeah, DOS. Yeah, MS-DOS. You guys have no clue. But when this showed up, the typewriter experts. I learned how to type on a typewriter, by the way. I went to college to learn how to use a typewriter, and it was hard work. I had to develop muscles and stuff. And then in the same college, they taught us how to use a computer. And it was worlds apart. I didn't have to use any, they called it feather touch. And the people who were experts in typewriting were threatened because the boss doesn't now ask me to type things. The boss types things himself onto the system and generates the letters that I used to do for him. So the secretaries who went and learned how to use a computer replaced the obsolete secretaries who could only use a typewriter. So even today, as a psychiatrist or a doctor, if you fear AI, you're going to be replaced by your colleague with the same qualifications who uses AI. So no need to fear, it is a need to evolve and move into the next generation of practitioners.
Thank you once again, Professor. Talking about integration, there is a major concern around privacy and also cultural context. Allow me to ask Professor Muthoni Maathai, what ethical safeguards must be put in place to ensure the responsible use of AI around privacy, consent as well, and the cultural context?
Thank you very much, and I'm not offended by being called Wangari. So, actually, when you think about it, like we were thinking about how we could, we had this proposal we were writing. Professor Atoli was there, Lynette. So how can we train sort of generative AI, Gen AI, using large language models to recognize our presentations of mental illness. Because what we have right now, what we have and what is going to happen if we don't do this is that they are going to be trained on the Western models of presentation of mental illness. Okay, when a woman or man from Kisii comes, Kisii particularly, no, excuse me, comes, no, she comes from Mount Alisonga Kuko. So when they come and tell you, yeah, there's that old woman in the neighborhood, me, I'm thinking it is like this, it's like this. I mean, this large language model that has been trained, this AI that has been trained in the Western culture, particularly Western middle class, will recognize that as delusions, and we will be asking, oh, really? Yeah. Where does she live? Yeah. And then we want to know, do other members of the family, is it within a certain cultural context? So we're going to be lost. And that is one of the problems that we face if we don't get in there now. We have to get in there now, otherwise we'll be diagnosing schizophrenia in our population among people whose beliefs are actually within their cultural context, because we are using AI that has been trained and by the narratives of other cultures. Now, so we were thinking about it, and we didn't get the grant, but we're still working on it and to do. Now, who owns these stories, the narratives? Let's say we go to Mathare. We have files that date back to 1930s, 40s, which would be very useful to digitize. Who owns this? And who can give consent for this? This is a real issue, and we don't have real guidelines at the moment for this. And so when you talk about that and privacy, for me, the biggest thing is not so much privacy, but the ethical issues of using people's stories who have no consent, or who owns this information, actually. And I don't know whether in your hospital they give consent to be in a safe server or something like that, because that is important. Because when we see patients like in the handwritten form, we tell them these stories are going to remain within the hospital. They are taken care of. You're not going to find your story being sold on the streets, because it's an interesting story. So I think these are issues that we need to think about. And at the same time, we cannot afford to be left out. So we need to really be there like yesterday. Yeah. Does that answer the question?
Yes,
Okay.
it does. Professor, would you like to add? I can see.
Yeah, so there's a lot of concern about privacy and data ownership and all that. And I think it's a nonsense concern. I'm radical in that sense. Because when you buy a phone, you sign up to losing your privacy. When you sign up for Facebook, or what do people use nowadays? I don't know. TikTok. Yeah, you go to TikTok, Instagram, Netflix, whatever. You go to the movie theater in Westlands. You are signing up to losing your privacy. You go to school nowadays. You sign up to losing your privacy. You attend a function at my university. You sign up to losing your privacy. So it's a nonsense concern. You have already given up all your data to multiple players. So when you're saying data protection and so on, it's nonsense. Because I know where you live. I know what you ate yesterday. I know who you are with. I know which roads you use. I know where you work. I know where your children go to school and so on. I know. Whether you want that to be private or not, I know. So the next thing is just to protect how that data is used. You just need to create regulations about how can you use that data. Can you use that data to come and kill me? Can you use that data to, and it happened a couple of days ago in Iran. They used that data and killed someone. I mean, so it's a nonsense concern about data privacy. It's a more important worry about how that data is used by those who have access to it. I think that's what the conversation we need to have going forward, about how data is used rather than who has access to the data. We have access to your data, whether you like it or not. Now, when you come to the hospital and we see you in the clinic, we will tell you, yeah, listen, I am going to collect data about you, all sorts of data. I promise you I'll only use it to determine how to help you. This is what I promise. I will only use it to determine how to help you. But as to what data I'm going to collect, I can promise you that there are some data I will not collect. I will collect as much data as I need in order to help you. So I think the paradigm needs to change. And whoever is listening today, there is no privacy Forget it. We know everything about you, and we can only promise you about how we will use that data, and you hold us accountable to how we use the data. Yeah.
The question, yes, Professor.
Quite agree with Professor Goye, because we are doctors, and through the history of medicine, we are sort of sworn to confidentiality. We have a certain responsibility. We are not social media. We are not Elon Musk and all the others who are there out for their own gain. But although we do have gain, but we really have a certain responsibility to our clients. And so I agree that it's important to tell that client who comes, this information is going to be recorded. And it's for your good and for the health. But we cannot just say there is not a need to be concerned. We need some guidelines. And maybe it's among ourselves that we need to develop these guidelines to advise the policymakers and say, this is where we go, so that people know. I mean, the thing about what's happening in X, it's really crazy, you know? Somebody has posted my picture there, and then suddenly you see yourself naked because some AI has undressed you. So this, it's scary situations, and should not happen within the medical profession, actually. But
so I think that's the final point I will make about this is that what we know is that the perfect AI model actually exists. The perfect AI model is a model that has all possible information. That's a perfect model. So that you can ask it, if I'm sick, it will help you with that. You can ask it, what should I have for lunch? It can help you with that. And so that's the perfect AI model. And so for a doctor, the perfect doctor is a doctor who has all the information that is needed in order to help you to get well. That's a perfect doctor. That doesn't exist. But AI can do that. It can get all the information. You can give it all the information it needs to keep you well.
Thank you. I'm loving this conversation because then this brings it to the reality. The truth is all our data is out there in one form or another. When you buy a new phone, like you've said, and make a few phone calls and Google a few things, then your algorithm completely changes. So the data is out there. But also the question begs in our responsibility as clinicians, how can we use that data in an ethical way and to help? I have so many questions, but I would like to ask Dr. Rajab one question. Being in a setup that is a government setup, how can we ensure that AI is incorporated with also without losing quality? Yeah, and how can we reach out? How can AI be used to reach out to more people? And then I'll share these other questions. I have so many that have come in, and I can see we are running out of time. So I'll share this with my panelists so they can be reading and answer.
Thank you, Gathoni. It's happy to be here. I think when we speak about AI and its possibilities in the healthcare setup and how it can help us better our care, is to see it as an augmentation to care, but not a replacement for the clinician or the therapist. It is a between session support, meaning it actually should be introduced by the clinician to the patient. That is, I think, the appropriate way. That the first time the patient should know to use AI is because you have introduced it to them. And then you also become the person who helps the patient keep checking in with you and the tool you introduced to her or him, okay? And then also the human touch should never at any point be lost. It means we always have to be there to keep checking what the system is saying and confirming that it is in keeping with ethics, it is in keeping with clinical practice and the guidelines that we have known them or continue to better them. The other thing is actually to also build strict escalation procedures. And I think the more we use AI, then we can be able to give it data so that it knows. We have had situations where the chatbot has actually shooed patients to complete suicide because it eventually learns and almost agrees with you if you do not know when to stop. So at what point does then the algorithm help it know when to escalate, to introduce the human aspect of care and not leave it all to AI again? Okay. So keep accountability human, the autonomy, the transparency, and the responsibility that needs to remain either with the clinician or the healthcare systems. Those ones we do not leave it with AI. As to how can it help us reach other or more people, especially, let's say, in resource-limited setups, I think we are at a situation where we are using task-shifting models where we cannot have trained mental health practitioners. Now it is the job of those trained to find time to now go and, again, train the people we've task-shifted to about the AI tools, so that as they do their clinical work, as they assess the patients, then they can use these algorithms to actually help guide the process of assessment, know when to prompt, let's say, for suicide risk, and when to start first-line treatment. And then from remotely, it can be monitored by now the clinicians, or let's say the more qualified professionals, is whatever going on the ground correct? Yes, and WHO has like the MHGAP tools. I think now those are things we can pass down there, train, and then eventually they can help augment care. Thank you.
All right. Thank you, Dr. Rajab. There's a question there. Please ask, and then we'll go into reading the questions we have.
Sorry, hi, Dr. Lucinda here. I was saying, sorry to take you back to the discussion you're having, because I felt it was a very important discussion to have, especially in such a setting. Now, I agree with Prof. Madai that, you know, your thoughts on data, privacy, etc. are not valid. One, because we are clinical practitioners and we owe the duty of care, but also because how I see such forums is we are supposed to try and think about how we are going to set up you know, systems and procedures to protect this data. So yes, data on your phone is owned by your technology company. Data on social media is owned by the social media company. Data in the hospital is co-owned by the hospital and the patient, not the hospital. So as medical practitioners, we cannot start the discussion by saying, we own your data. No. We have to first think about how are we sharing this data. We are in an age of patient-centric care. You know, in the West, we have direct-to-patient studies. So companies don't have to come to hospitals to do studies. They go to the patient because they know the primary custodian of the data is the patient. In the hospitals, for example, with this data in Mathare that you are saying is from 1945, there are systems in place, ethical systems. You know, you can get ethical approval to collect this data as de-identified data. The main reason being it's personally identifiable data. So as we are thinking as psychiatrists, incorporating AI into our practice, training these models, because we can only train them with our clinical data, we have to think about, one, the patient, they have to consent because it's personally identifiable data, like genetic data. And two, we have to lead the conversations in how we set up systems to protect this kind of data, even for the AI companies, because nowadays people go to chatbots and use them as psychologists. There's no one who's going to go and tell OpenAI or this new one, Claude, that when people who have signed and agreed to all your terms and conditions give you data about their private lives and how they want to kill themselves, etc., it's unethical for you to store it and use it, you know, to map out social ads, etc. It's us, because we are the psychiatrists, we're the ones who know the implications of all this. So the conversation shouldn't start as, we own your data is lost. The conversation should start as, we know there's this data, we are the custodians. We want to start the conversation on how we can protect this data.
All right, thank you so much for that comment. We will address the questions briefly.
I agree with your premise that we co-own the data. Obviously, the generator of the data is you, so you own it. But we also own it. We also own it 100% because you've given it to us. Your worry should be, how am I using that data, rather than what data do I own? You have given it to me already, I own it. I'm not going to erase the fact that you are suicidal. I'm not going to erase the fact that you didn't sleep well last night. I own that information already. How am I going to use it? And how I'm going to use it is more important than the fact that I own it. So if I use that data to direct you in a place where a person who has suicidal ideation is not going to attempt suicide, if I use it in that direction, we can agree that that's a good use of that data. If I use you in the direction of I use the data in the direction of pointing you to a method of killing yourself, then we can agree that that's not a good use of that. The code should specify how I use the data, but not whether I own it or not. Once I have access to it, I mean, it's out of control. We can't say I don't own that data. I own it by the fact that you have exposed me to it. So that's, I think, my primary premise. The ethical thing is how you use the data, not whether you own it, not whether you have access to it, and so on. That's determined by other factors. That's where I'm coming from with that.
Please answer one question.
Okay,
one question each.
Right.
From
this,
what we have, yes.
Yeah. I will talk about the curriculum, because a couple of people have asked about how are we integrating data science, AI, machine learning in medical school curriculum. And somebody has also asked about what happens to the syllabus curriculum in medical schools, especially clinical skills, examination, and so on. And I'm here to tell you that medical schools that use AI will quickly replace medical schools that don't. If you, in your medical school, have said we don't use AI and so on, that medical school is going to close. Just live with it. So we use AI. We use AI already. Our students use AI before they come to medical school. So we have to think about how do we leverage that ability to use AI in helping them to learn faster, to learn more, and to learn more current stuff. So we use that. We use AI in designing our presentations and so on. We use AI in setting exams to ensure that the exams are objective and everybody's exposed to things of the same complexity and so on. We use AI to do that because humans are imperfect. If I see you, I don't like Frank, and then you come, I'll ask you a hard question, and then I will not agree with your answer. Whether your answer is right or wrong, I will disagree with it. But AI helps us to standardize that process. AI helps us in many ways. So it has to be incorporated in how we teach. It has to be incorporated in teaching so that we teach our students what AI can do and what AI cannot do, what risks and benefits are there with AI. We have to teach them so that they use it responsibly.
All right. Thank you so much, Professor Atwoli. Okay. Professor Muthoni?
Let me answer the question. AI use can be addictive. How do you manage over-reliance by clinicians? I think our problems should not be the clinicians. What we have a problem with is people, non-health providers, non-professionals, who particularly young people who are using AI and getting addicted to it. That should be our concern. There's now the emerging AI psychosis, which is a delusional kind of psychosis that is encouraged by AI use. So that is where our concern is. And as clinicians, we should treat AI as complementary, and that goes to the next question. It complements our knowledge. It's a quick way, but you must check. If you, for example, you write an article or an abstract or something, which one time I did, quickly, though I didn't need an abstract, quickly write one, AI, ChatGPT, and then some of the references did not exist. Exactly. So you have to counter check It was a surprise. Oh my God, where is this article? It doesn't actually exist. So you have to counter check. That's our concern, not overuse. Overuse, we are concerned about the non-health specialists. Thank you.
Thank you so much, Professor Modoni. Dr. Rajab, please.
I will answer, will AI improve access to service, and will it reduce the cost of the same service? For the first one, yes, it will improve access to service, because one, even before a patient comes, is that it can help, with preventive care. That can we know someone's behavior is changing. Access to information even before the first contact with a clinician. And when they come, just by reducing the load on the clinician that we used to, like Prof has said, the notes will be taken for you, the differentials can be done for you. That means you can actually take slightly less time doing administrative and paperwork time. That means you have more time on your hand to see more patients effectively, and that in itself improves care. Cost, I'm not so sure about that yet. Thank you.
Thank you so much. Please allow me to end this here. We have gone way ahead of our time. I would like to invite all the panelists to take a group photo. And as they do that, I just want to emphasize that what we've had today here is that innovation must walk alongside ethics, and that progress must remain grounded, and that even as machines become more intelligent, the essence of healing must remain profoundly human. I know you all have a lot of questions. This is a conversation that cannot be done in 1 hour. And our panelists are here, and I hope that you can engage each one of them. Thank you.
Thank you very much. Thank you very much, panelists. This has been a very wonderful morning session on artificial intelligence. I think from the conversation, maybe those involved in coming up with debates might have come up with a debate question. Seems there were some two differing opinions about something. The other thing is that we have learned that AI will not replace doctors or professionals. It's professionals who use AI that will replace those who don't. It's been interesting because in this digital era where we are using AI a lot, even our wearable devices, they can tell how anxious we are before even ourselves. It's almost like a digital mother. So sorry for us. So right now it's time for a quick break. We will have refreshment served just behind here. Right now it's about 10:39. We should be back by 10:59 so that we start the session at 11. Thank you very much. Welcome.
does HR feel with
fall depressive symptoms.
Welcome back, the team outside. Welcome back for the mid-morning session. Issue around personalized mental health. We are here to talk about emerging issues. Most of the time, the word emerging issue is not very palatable to us. Most of the time, we hear patients say the emerging issue at 4:55 p.m. and you are almost on your way out of work, but you still have to listen to the emerging issue. So
innovations in medical aesthetics, trichology, and advanced regenerative therapies. So with a focus on personalized medicine, Dr. Malde champions a paradigm shift, moving beyond traditional aesthetics towards science-driven wellness, prevention, and cellular regeneration. Through cutting-edge treatments and specialized training programs for physicians across the region, she is redefining how health and well-being are understood and delivered. I'm honored to welcome you to be our keynote for the next session. Please come.
Good morning, everyone. I'm not so tall, so I hope you can see me because I think this is covering me. But as long as you can hear me, I'm here to talk about something that's very sensitive in this day and age. So when we talk about obesity today, we need to start reframing the conversation. That's what I'm here to talk about. This is a service that I provide in my clinic, experienced firsthand myself. And I think a lot of us, even as physicians, suffer from the same. A very sedentary job, sitting behind our desk, 8 to 8, no proper lifestyle, diets haywire, and I think this is what our patients suffer from as well. So obesity is not simply a matter of discipline, motivation, or personal choice. It's a chronic, relapsing, and multifactorial disease influenced by genetics, neuroendocrine regulation, metabolic signaling, environment, and behavior. Yet, despite decades of science evidence, it continues to be widely framed as a failure of willpower, which is not true. So this narrative has real consequences. It creates stigma, delays medical intervention, and often leads patients into cycles of guilt, restrictive dieting, which most of us can't do, and weight regain rather than sustainable treatment. So we went one step ahead to introduce or to figure out how this weight loss regimens or programs can be sustainable, because that's where most weight loss programs fail. They're just not sustainable. And I think a lot of us here in this room are victim to it as well. And over the past few years, however, we've seen a major shift in how obesity can be treated. So we offer glucagon-like peptide-1 receptor agonists, or GLP-1 therapies, GIP therapies, GCGR therapies, that represent a significant evolution in obesity management because they address the biological drivers of appetite and metabolism rather than relying solely on behavioral restriction. These medications work centrally in the brain to reduce hunger signals, enhance satiety, and regulate reward-driven eating behaviors. At the same time, they work peripherally to improve insulin sensitivity and broader metabolic health. The result is that patients are able to achieve a consistent reduction in caloric intake without extreme dietary rigidity, starvation, or unsustainable lifestyle changes. When integrated into structured medical programs, GLP-1 therapies have shown durable weight loss, improved cardiometabolic outcomes, and significantly higher long-term adherence compared to traditional diet-centric approaches. But the impact of these therapies extends beyond metabolic markers. One of the most important shifts we are observing is a change in how patients understand their own relationship with food and body weight. When obesity is reframed as a biologically mediated condition rather than a personal failure, patients often experience a profound reduction in shame and self-blame. Many describe for the first time a quieter relationship with food, less intrusive hunger, less compulsive eating, and greater control over their decisions. This shift has important implications for mental health professionals. While GLP-1 therapies are not designed primarily as psychological treatments, emerging clinical observations suggest indirect benefits such as improved self-efficacy, reduced weight-related distress, and enhanced overall quality of life. For many patients, the treatment creates space for healthier behaviors to finally become sustainable. From a biopsychosocial perspective, this highlights an important point. Obesity care is no longer just about diet and exercise. It increasingly requires integration between metabolic medicine, behavioral health, and long-term lifestyle support. So as clinicians, understanding these therapies allows us to move the conversation away from blame towards more evidence-based compassionate care. Ultimately, treating obesity as a legitimate medical condition rather than a moral failing may be one of the most important steps we can take in improving long-term health outcomes for our patients. Thank you.
Could we have another round of applause for Dr. Ashney? Thank you so much for highlighting treatments in obesity using different new modalities, including GLP-1s that we have been hearing about. So if you have any questions, kindly note them down. We'll take them during the panelist segment. So our next speaker is a research scientist at the African Population and Health Research Center. So this is Dr. Simon Kariuki. He's a visiting scientist as well at KEMRI Wellcome Trust Research Program in Kenya. Over the past 15 years, his research has focused on epilepsy, psychiatric comorbidities, specifically characterization of the burden, clinical features, and consequences. In his work, he has employed neuropsychological, electrophysiological, and neuroimaging approaches to better understand the features of neuropsychiatric conditions. So with the aim of informing and optimizing treatment strategies and improving outcome prediction. So let's welcome Dr. Simon.
Thank you very much for the opportunity, especially the organizing committee. So I'll be speaking today on a topic that I was assigned on the diagnosis. That's the advances that have been made in the area in terms of preventative interventions and also management interventions with a focus on dementia. But I just wanted to start, and she's already mentioned that I previously used to work on epilepsy mostly and the comorbidity with the mental health problems. But I think the interest in the challenges that the elderly people face started some years back based on some work that we were doing. And that was in 2018, extending all the way to 2019. And we intended to do a study on the behavioral and the quality of life of elderly people living with epilepsy. And we faced quite a number of challenges. So the first challenge was recruitment. So we couldn't get participants beyond 50 and 60 years. And as you can see, of the people that we were approaching, even among the adult population of up to around 60, only around 31% of them could actually participate in the study because of intellectual disability. But I think at that particular time, we didn't have quite a very good understanding of what could have been happening. Even among the participants that we recruited into the study, and that's in the next slide, please. So a substantial number of them, that's around 32%, could not complete questionnaires on cognitive impairment, executive functioning, and also when we asked them to do very simple tasks for intellectual quotient, so they could not be able to. That was just an indication that there was some cognitive impairment going on in that adult population. But I have to admit that at that particular time we didn't exactly know what was going on. But on a related study that we were doing with one of our PhD students, who is now working with Professor Atwoli, so we attempted to find out how the community was understanding mental and neurological disorders on the Kenyan coast where I was working back then, and we faced another challenge. So nobody actually could provide a local terminology for dementia that they could do for so many other conditions, meaning that it was not very well understood in the local population. However, when we asked them about the manifestation of dementia, many of them could actually relate with what happens in the community, forgetfulness, and also sometimes disorientation, especially when somebody is driving to a place. And that just highlighted the extent gap that is there in the dementia research. Next slide, please. Next slide. I think I'll just touch a little bit about dementia diagnosis, because there is usually a lot of confusion between dementia and also other subtypes of dementia, especially the Alzheimer's disease. Alzheimer's disease is just one of the commonest type of dementia. There are so many other types of dementias, including vascular dementias, including frontotemporal dementias, and so many others. But there is usually a criteria, and the main one is impairment in cognition. And it has to be across so many domains, and how you go about that assessment also matters, because as a clinician you can just do it the way you do routinely in the clinic, but you can also decide to use a standardized assessment scale. So if you want to get very accurate estimates, the best way to go is to use standardized scales that are available and that have been adapted into the local setting. And then after that you go to criteria B, which is very important, and assess the level of functional impairment in that particular patient. That you're going to do it in two ways. If it is very significant functional impairment, then you'll consider that one a major neurocognitive disorder. But if there isn't much, or there is just mild functional impairment, then you'll consider that a mild neurocognitive disorder. And that's very crucial, because when it comes to comparing estimates between the DSM-5, and we've heard quite a lot about it this morning, and other assessment criteria, DSM-5 is usually very conservative. And I think it's just because of that aspect of requirement for there to be perturbations in functioning of the patient. And then after that, you just ensure that it is not in any way related to deliriums or to any other mental health disorders, and make sure that you also get some time to do the classification, as we've said, for the different subtypes. But the process is provided there on how you arrive at that, and it's very important because we'll be discussing a little bit of that. So beyond the clinical history and the cognitive testing, you also need to do some other ruling out. For instance, there could be some causes of non-reversible dementia, micronutrients, vitamin B in particular, thyroid disorders. Most of the psychiatrists would actually ask you to go get checked for that. And then also trying to establish what is the neuropathological nature of the dementia that the person is having, whether it's structural or whether it's vascular. And in that case, you need to do neuroimaging, either structural MRI or functional MRI. So is this important, and why are we interested in dementia at the moment? I think it's very important, considering that at the moment, as we are seated here, there are about 50 million people that are living with dementia. I used to work on epilepsy before. The estimate were being given at 70 million, and there was quite a lot of attention and investment in that condition. And I'm hoping that there should be the same much of investment in dementia, because 50 million is not a small number. And if you project that to 2050, so it's actually going to get to almost 160 million. So that's going to be very enormous. And that is actually expected to increase or to be contributed significantly by countries which are from resource-constrained settings, including ourselves here and also other countries in Africa. And while other high-income countries are actually witnessing a decline in the incidence of dementia, obviously because of the investment in care services, they can be able to manage most of the causes. In Africa and in other low and middle income countries, we are seeing an increasing trend. And that's what I'm trying to demonstrate with the map on the right there. If you look at Africa, most of the country are actually reporting an increasing trend. So we may say it's because there was a lot of attention in rich countries before, and therefore their baseline estimates are high. And when you are actually tracking progression over time, you'll actually see a significant difference. But I think because we have risk factors in our setting, then we need to take that very seriously. So the estimates will definitely depend on the method that you use. As you can see, the population in Africa, it's been established that the incidence may be significantly higher in black population, and it's also common knowledge that with increasing age, the burden is also going to be significant. So if you want to get very accurate and representative estimates for planning purposes, the best thing is actually to do a community-based study. Next slide. The one on risk factors and causes. All right. So according to the recent Lancet Commission on the Care for Dementia, so they have actually identified 14 important risk factors for dementia. That is actually a 2 risk factor increment from the previous list of 12 risk factors that had been identified. Obviously, that's a very conservative number compared to what is actually found in the literature. But they used a criteria to arrive at that in terms of consistency of a risk factor. If it is consistently being reported across studies, then they would list it among the 14. And if it is also biologically plausible, for instance, if you are having hypertension, and we've mentioned about vascular dementia, then there is a biological plausibility that it can actually lead to dementia. So they narrowed them to 14, and from the previous commission, the 2 that were added included cholesterol and also visual loss, or visual impairment, and that's what brings the total number to 14. So they either considered also some causes as not risk factor. I'm just indicating there, just in case you don't see them in the figure, especially the stroke and also other neuroinfections that I've listed there, because they can directly break the blood-brain barrier and enter into the brain and directly cause damage. And if you can be able to confirm that, then they should be considered causes and not risk factors. And the most important message here is that there are 2 types of factors: those that are conferring the risk, increasing the risk, and quite a number of them, including genetics, which has already been mentioned by the previous speakers, medical factors, especially the head injuries, and also environmental pollutants. And environmental pollutants are important because they are actually complicated by the climate change, especially excessive heat, and that has been mentioned today, but also other activities that are happening in the communities, including the type of pesticide that people are using. And pesticides have been associated even with the development of Parkinson's disease, which is sometimes considered a subset of dementia. But the most important thing which is reassuring is the protective factors. And the point that I want to emphasize there, because I will be touching on the others as we proceed, is the brain and the cognitive reserve. And that's why people are usually affected differently. So that's the size of the neurons, if you can be able to confirm that, and also the ability for your neurotransmission to be able to apply alternative compensatory mechanisms. If that is established, then you probably can be exposed to the same risk factors as another person, but you are not going to develop dementia very early. Perhaps it might develop at some point, but it is also going to be delayed. And other things that we'll be touching on, and they have been mentioned by the previous speaker, is on the lifestyle changes, including even weight loss, so which significantly reduces the risk. Next slide. So I wanted to just touch briefly, and I quite like the discussion in the morning, especially when there was emphasis on the fact that the DSM-5 will need to be inclusive of other pathogenetic processes when actually describing mental illnesses. So for dementia, in as much as we do not fully understand the pathophysiological process or the pathogenetic mechanisms, we know that there could be a problem to do with the glucose metabolism, and therefore the brain and the neurons are actually starved of glucose, and that obviously results in neurodegeneration and the cell death. It's similar or consistent to what we know as hypoxia. And then the vicious cycle starts, because the moment you just have some parts of the brain not functioning optimally, you are probably not utilizing them cognitively to the maximum, even in terms of the motor activity. When you don't do that, it affects the brain plasticity, and then you just start to see the reduction in size of the brain progressively, starting from the initial insult and also because of the disuse related to the damage that has been caused. And when that cascade process is started, then there are some initial symptoms that are going to start. And I'm highlighting some of them there, including some of the non-communicable diseases in case there are people that are interested in that area. So diabetes, hypertension. So if you're going to get checked, it might be just in the earlier presentation of the condition, but then also other symptoms are going to follow thereafter. Sleep problems, olfactory problems, and also psychiatric manifestations, which are usually very common in people with dementia. I think the reason why understanding this is important is because at the moment the treatment option that we have, and I'll be touching briefly on that, are symptomatic oriented, just working on the symptoms, and we do not actually have a lot of disease modifying agents at our disposal. And therefore, the more we understand the pathogenesis process, the more it is likely that there will be investment in the discovery of disease-modifying agents, and then that's going to reduce in the direct reduction of dementia, as we shall demonstrate on interventions on hypertension. Next slide. So I'll quickly go through the biomarkers, which I was asked to touch on. And before I do that, just to mention that autopsy is usually a very definitive way of diagnosis. And so obviously symptoms will have happened there, but that's when you will be able to clearly see that there are changes in the brain. But then you can't wait until then. So you have to do magnetic resonance imaging very early on, because if you can identify a pathology early and then you start treatment, then the prognosis is going to be better. And this is very, very crucial, because some changes are unique to different types of dementia, as you can see there, especially the dementia with Lewy body. So the temporal areas are usually preserved compared to the Alzheimer's disease, the frontotemporal areas. And then you can also use other strategies where you can check the functioning of the brain, metabolism, and also the way the blood is flowing. What is most important is the advent in discovery of some tracers that can be used in positron emission tomography. And I'm just highlighting some examples there. You don't really need to know them. I think all you just need to see is that the different parts of the brain are lighting up differently. For instance, the shaded areas in blue there, so they're actually showing some hypometabolism in the temporal, parietal, and frontal areas. And if we can be able to leverage then on these developments, we can actually be able to confirm that there are problems. Next slide. On fluid biomarkers, I think most of the ones that are very popular are the amyloid beta biomarkers, and they usually form plaques in the brain, and also the tau proteins. But the take-home message is it is easier to do this in cerebrospinal fluid than doing them in blood, because blood is unreliable. But I think the technology is improving now, and we are starting to see much more reliable quantities going forward. But also the direction matters, especially for the amyloid. There is usually a depletion in the concentration of it in the CSF, which is opposite to the tau proteins, because tau proteins are just a marker of brain damage. Next slide. So I think we can use the fluid biomarkers if we are very optimistic, maybe to improve diagnosis, but I think we need to combine so many of them so that we can increase sensitivity and specificity. At the moment, we may just need to rely on them in distinguishing the pathology of the disease, and also tracking the progression, and also deciding when to initiate treatment. As you can see in the figure there, in the early on phases, that's when the amyloid proteins and plaques are usually seen, and therefore you can start planning on what treatment to use. But on the later stages, when you are developing psychiatric manifestations, abbreviated there as BPSD, then the strategy of management might also need to be different. So I think the aim here at the moment is not just to get a solution for diagnosis, but it's to understand the disease much better, and also to clarify that even if you find so many biomarkers present, they may be having a relationship with the risk of dementia, but as you can see in some of them in the figure there, and in the next slide, please, next slide. Next one. You can even have like two of them isolated but you still don't have the risk of dementia because sometimes it takes time before the symptoms can develop. So just touch briefly as I conclude on the management options and say that we don't have curative treatment, and that's a fact. And I think the only thing that we can do at the moment is to delay onset and the cognitive decline, and also to relieve the symptoms so that the patients can have a good quality of life. So there are some pharmacological options that are available, and I'm giving some examples there, and I think they could be at the disposal of the doctors and the psychiatrists. And there are also others that are actually under trial, but majority of them are just for controlling the symptoms. They are not going to get the disease go away. Next slide. Next. Yes, so there are a number of ongoing clinical trials at phase 3, so that's some good news, and they are premised on the amyloid therapy and also on the relief of behavioral psychological symptoms. But I think we need to do much better than that and to discover new disease-modifying agents like I've said. Next slide. So emphasis should be on public health approaches, all interventions, and understanding that there is an accumulated risk period for dementia to develop. Therefore, you have to start very early on. Even actually at the youthful period, that's when most of the risk factors are happening in one of the area figures that I shared. And because of that accumulation, then you may not use dementia as an outcome, because sometimes you might wait for too long and it will be too late. Just need to come up with some of the biomarkers that we've mentioned and use them, some of the risk factors, and use them as your outcome, and you may be able to understand the disease progression, also the effectiveness of the interventions. But also equitable access to interventions is very important, because these conditions are affecting the most socioeconomically deprived people. And I think before we carry out those interventions, we also need to contextualize them into the local setting. Next slide. So I wanted really to show this example of treatment of hypertension. If you start it very early in midlife, as you can see there, the meta-analysis, it was actually associated with reduced risk for development of dementia. And that is if you start very early on in the midlife. And it is simply because some of the medication that you use, especially the calcium channel blockers, so they are very beneficial because they work directly also in the brain, that they are blood vessels, but also improved hemodynamic, which I think improves the process of recovery and also slowing down the decline. So that's a very good, perfect example of how you can use a public health intervention to reduce the risk of dementia. Next. And there are so many other examples in the literature. In case you are interested, there is that study from Finland, the FINGER RCT, which is a multi-component intervention looking at different aspects: diet, cardiovascular risk, weight loss, and so on. And it was very beneficial, actually reducing cognitive decline and reversing it. And it was mostly beneficial in the people that on MRI and very, very thick cortical gray areas and white matter. And therefore that's very crucial, which is what we've called the brain reserve. And also another study from Netherlands there, which focused mostly on self-management. Again, public health intervention on cardiovascular risk reduction. Next slide. We also need to think about the people that are taking care of those with dementia. And again, we should think about the intervention that we should come up with beyond the treatment, because sometimes we just treat within the hospital and then we don't care about what happens outside there. And many of the caregivers are experiencing a lot of psychiatric problems because of the burden of taking care of these people. So when we are planning interventions, let's have something comprehensive that is also going to take care of the post-discharge period. Next slide. So the take-home message, and this is my last slide, is the fact that dementia remains a growing public health problem. And even if I've been able to demonstrate to you that there are so many people probably living with it, and I suppose that it is an underestimate, we still have very few epidemiological studies in Africa. And I think that will be the first place to start, understand the epidemiology and also the natural history, and then also prioritize on the risk prevention. I showed that figure showing that if you can actually consider all the 14 risk factors, you're going to reduce about 45 of the burden of dementia. But then we need to take a life course approach. We only see it as a disease of the elderly, but I'm telling you the problems would have started much earlier, even during the early 40s, mid 40s there, and how you live your life around that period will determine how the risk will be when you get to your 60s. Strengthening the healthcare system, and that's the entire care pathway from the community to the hospital, and again, after discharge, supporting the family members, but also thinking about this is going to be sort of like a very intensive investment in discovery of disease-modifying drugs, and also continuing to build up on the knowledge that we have on the biomarkers, because at the moment we can't use them for diagnosis. And then finally, and this was covered, is leveraging on digital health technology. It was very covered adequately. Unfortunately, even if it can actually be used across the care pathway, there is very limited evidence on its feasibility and cost effectiveness, especially in Africa. Thank you very much for your attention.
Thank you so much, Dr. Simon, for taking us through your presentation. We see the prevalence of neurocognitive disease quite high in our context in LMIC, and directions going forward in terms of understanding more on the pathogenesis, neuroimaging and biomarker use, and ultimately treatment directions. So if you have any questions, kindly write them down. We'll take them at the end. I'll introduce our final speaker. This is Dr. Kimutai Katwa. He's an early career psychiatrist based in Nandi County, holding a Master's of Medicine in Psychiatry from Moi University, where he also served as the Chief Registrar. His clinical and academic profile is well-rounded. It encompasses active community psychiatric engagements, research experience with NeuroGap, where he was a research assistant, and a thesis which looked at relationship between schizophrenia, bipolar mood disorder, and alcohol use. So Dr. Katwa brings a notable international exposure. He's undertaken external rotations with Brown University-affiliated hospitals, covering child psychiatry, adults, addiction, and geriatric psychiatry, and neurology. Most recently, he represented Kenyan psychiatrists at a neurology course in Namibia. So let's welcome Dr. Katwa to take us through his presentation.
Okay, thank you all, and thank you Chiromo Hospital Group for considering my submission, and thank you for inviting me to present it. So today I'm going to present about the bridge between the various fields that treat the brain of a human being. I think Prof. Atwoli had talked about it earlier. So recently I went to Namibia, and I went through a course that trained us on various neurostimulation interventional techniques to manage brain disorders when biological interventions fail us. So my name is Dr. Katwa, and I'm a psychiatrist. I work for Nandi County. So the background. So last year in November, I was invited to Namibia by European Academy of Neurology and African Academy of Neurology to undertake a training. It is called RTC, that was conducted in November. And during that training, we were taught about various cutting-edge interventional techniques for management of psychiatric and neurological disorders. So the focus of the training was it emphasized on the multidisciplinary approach to brain disorders. That was the approach that encompassed neurology, neurosurgery, and psychiatry. And it also covered neurodegenerative disorders that have already been covered by the previous speakers, and that is Alzheimer's disease, Parkinson's disease and other types of dementias, also seizure diseases, and also psychogenic non-epileptic seizures and functional neurological disorder. So it also covered emerging therapies most relevant to psychiatry, and that was deep brain stimulation, responsive neurostimulation or RNS, and vagus nerve stimulation or VNS. This being the latest techniques used for neurostimulation therapies that are going to replace ECT. We all know the weaknesses that ECT has. So these therapies are newer and are emerging to replace ECT, which we are more familiar with, so we are not going to discuss it today. So the three key modalities were, as I mentioned before, DBS, RNS, and VNS. So these neurostimulation therapies represent a major advancement in the management of neurological and psychiatric disorders. And these therapies modulate the abnormal neuronal activity, and it is more targeted, and it offers personalized therapeutic benefits as compared to the older neurostimulation techniques such as ECT. So the first one is deep brain stimulation. So deep brain stimulation is a sophisticated neurological intervention, often described as pacemaker for the brain, a nickname it shares with the responsive neurostimulation, which is RNS. So it involves an invasive procedure. So there is implantation of electrodes by neurosurgeons into a specific region of the brain. So these regions will have already been mapped out by either a neurologist or a psychiatrist. So the neurosurgeon will implant the electrodes. I will explain how it is usually done. So how does deep brain stimulation work? So the DBS system consists of three key hardware components. So those are the electrodes that are implanted, which are leads. So these are thin wires surgically implanted by neurosurgeons into the brain targets that have already been identified either by a neurologist or a neurosurgeon, a neurologist or a psychiatrist. So these electrodes connect to extension wires. So the extension wires are subcutaneous wires that run from the brain through the scalp, under the skin to the chest area, and that is where the nickname neuropace or else neurological pacemaker comes in. So these extension wires will connect to a neurostimulator in the chest, and this neurostimulator in the chest is a pulse generator. It's a battery-powered device that will generate pulses that will stimulate the target areas in the brain. So the neurologist or the psychiatrist programs the device to deliver customized simulation parameters regulating abnormal brain signaling. So long-term efficacy in movement disorders has been established. So this DBS is primarily used to manage movement disorders, and these are neurological disorders. So it's neurologists who will be using it to manage the movement disorders, which will include essential tremors, Parkinson's disease, or dystonias. And these are advanced therapies. So the neurologist or the psychiatrist will first do testing, brain imaging testing, such as positron emission tomography or PET studies, or functional MRI studies to identify the problematic areas, and then these problematic areas will be where the simulation goes in. So in psychiatric disorders, it is being increasingly explored as a modality of treatment that is more targeted for refractory disorders in psychiatry. So that is treatment-resistant depression and OCD, obsessive compulsive disorder. So it is not yet explored for treatment of schizophrenia or bipolar disorder. So when treating obsessive compulsive disorders, they target the caudate nucleus and the orbitofrontal cortex for stimulation. And when treating treatment-resistant depression, they target the subcallosal cingulate area or Brodmann area 25 for stimulation. So the rationale being that when these areas are stimulated, the neurotransmitter activity is modulated and the symptoms of the disease are relieved. So they are also used in cognitive disorders, which the previous speaker talked about. So emerging research focuses in cognitive circuitry, where such as when treating Alzheimer's disease, they target the phonics area, that is the hippocampal pathway. And the rationale here is to enhance memory formation and retrieval. And when treating tardive dyskinesia, which is a medication-induced movement disorder, or pseudoparkinsonism, also another type of medication induced movement disorder, being as side effects of antipsychotic use, then the target areas are the same as those organic movement disorders, or the ones that occur without medication inducement. And the areas targeted are the globus pallidus, internus, or GPI. This is evidence-based to reduce symptoms in drug-induced hyperkinetic disorders. Also, the basal ganglia is targeted to disrupt the basal, to stimulate the basal ganglia circuitry. Other selected cases involve subthalamic nucleus stimulation and thalamus stimulation. As we all know, thalamus is the relay station of the brain. So when you stimulate that area, it covers a wide range of movement disorders. So summary of DBS targets are as follows. For movement disorders, it is GPI, subthalamic nucleus, and the thalamus, which are the target areas. And these ones will treat either primary or secondary movement disorders, being Parkinson's disease, tremors, dystonias, Tourette's, and what I mentioned as antipsychotic-induced movement disorders, which include tardive dyskinesia and pseudoparkinsonism. So for psychiatric use, caudate area and caudate nucleus and area 25 are usually stimulated for treatment of OCD and treatment-resistant depression. So for treatment of cognitive disorders, which will include Alzheimer's disease, hippocampal area and the phonics are stimulated. And this one will treat Alzheimer's disease by improving memory retrieval. I already covered that. So the next modality is almost similar to deep brain stimulation, and that is responsive neurostimulation system. So RNS system is almost the same as DBS, but with one major difference. So the RNS system is not, the stimulations are not done by a neurologist or a psychiatrist. The stimulations are automated in the sense that the RNS system will read the brain's waveform and will try to identify an epileptic waveform before it happens and automatically trigger a stimulation that is going to cancel out those neuronal hyperstimulation caused by the caused by the seizure area beginning to create an epileptic waveform. And in that case, it responds to it in time, and it responds to it immediately. So the RNS system is a closed-loop system of neurostimulation. The mechanism of action is, unlike DBS, which provides continuous stimulation as programmed by the doctor, RNS is responsive to the brain's waveform. So it continuously monitors the electrical activities, detects it, and responds to it in real time. So the clinical outcomes are very good, with 75% median seizure reduction in a study that went for 9 years. That is as per Cleveland Clinic in 2019. So improvements in cognition and mental health occur either directly or indirectly. So indirectly is that when someone does not have seizures, number one, their cognitive health improves, because we all know that seizures will lead to cognitive impairment. And number two, when you don't have seizures, a lot of seizures in a day or in a month, then your quality of life improves. And in the biopsychosocial modeling of mental illness, when your quality of life is good, you are less likely to suffer stress-related mental illnesses. So this is how move to the slide which shows the electrodes placement. So the next one. So this is how the electrodes are placed in an RNS system. So electrodes, the tests will be done, such as positron emission tomography and functional MRI scans, to identify the problematic areas in terms of epileptiform, or else neurons that will generate an epileptic waveform. So the electrodes will be inserted to target those areas, and they will be wired to an RNS neuromodulator that is placed on top of the scalp. And that RNS neurostimulator will be reading the waveform of the brain, and when it notices a problematic waveform, it stimulates the area to treat the seizure. So next slide. So RNS systems will have various clinical benefits, like personalized simulation, because it reads your brainwave in real time, and it will have median seizure reduction of 75%. So it is highly effective, and it will improve cognitive and mental health, directly, I said, or indirectly. And another question that arises now is, if RNS is used to treat epileptic seizures, is it useful in treating non-epileptic seizures? So RNS is not useful in treating psychogenic non-epileptic seizures, which you also encounter a lot as psychiatrists. Why? Because the brain does not have, there is no electrical dysfunction in terms of how the brain's electrical activity is affected in psychogenic non-epileptic seizure. So there is no epileptiform signature in PNES. So that is why RNS cannot be used to treat PNES, because RNS responds to problematic epileptiform signature. So the next modality of treatment is called vagus nerve stimulation, or VNS. Now VNS is an older type of neurostimulation, so it's not as new as the others, and it has two key different formulations in it. So there is the non-invasive one and the invasive one. So the traditional one is the invasive one, whereby a generator is implanted, similar to deep brain stimulation, directly into the vagus nerve, and a stimulator is placed on the chest, and the doctor will be stimulating the vagus nerve as per need. And the newer modality is the transcutaneous auricular VNS. So this one is non-invasive, and it uses or else it takes advantage of the fact that the vagus nerve has a sensory component to it that goes to the ear, the pinna of the ear. So those are two regions, that is the tragus and the cymba conchae. So I've already put an image there to show where those areas are. So there is a sensory component of the vagus nerve that goes here, so the stimulator will go there and stimulate it from the surface. So there is no implantation. So this one is non-invasive. So in medical applications, vagus nerve stimulations will be used to treat epilepsy, not as effective as RNS, so with 50% average seizure reduction as compared to 75% previous in RNS. So it also treats pain disorders like migraine and chronic headaches. It also modulates the gastrointestinal function through the gut-brain axis, as the previous presenters talked about, and also modulates inflammation and motility in the gut. As you all know, when you have stress, you get overproduction of gastric acid. So as we all, so because of that, we know that brain health is largely connected to gut health, and that once you modulate the gut-brain axis, then you'll be able to achieve better brain health. And we all know that the vagus nerve is one of the biggest cranial, it's actually the biggest cranial nerve, and goes all over the body, including to the gut. So there is also stress regulation, as I've said. The vagus nerve is involved with stress modulation, and this one is done through HPA. When you stimulate the vagus nerve, you also modulate the HPA axis. So finally, and this on vagus nerve stimulation in psychiatry, it can be used to treat treatment-resistant depression. It can be used to modulate neurotransmitters such as serotonin, norepinephrine, and GABA. It can be used to modulate HPA axis, which I've already talked about. It can be used for brain-body integration, like the brain-gut integration. And also, it recalibrates the fight or flight response to rest and digest. So meaning, it recalibrates the autonomic nervous system from preference of parasympathetic nervous system to prefer, or preference of sympathetic, that is fight or flight, to parasympathetic, which is rest and digest. So to conclude my presentation, DBS, RNS, and VNS are approaches to neuromodulation that can be used in a better targeted way to treat conditions that we use ECT to treat. So DBS is a circuit level modulation, and it is a continuous stimulation, and it's a psychiatrist or the neurologist who does the stimulation to the targeted areas. RNS is a closed loop seizure detection and interruption, so the doctor is no longer involved after placing it. So the system works automatically. VNS is a broad neurostimulatory modality that utilizes autonomic nervous system innervation through the vagus nerve to modulate various biological causes of mental illness. And then the advantage over ECT is that it is more targeted and more personalized. Thank you. I have my references there. Thank you very much. Yeah.
Thank you so much, Dr. Katwa. So now I'll welcome our panelists, Dr. Arshni, Dr. Simon Kariuki, Dr. Katwa, and Dr. Kemunto. Kindly come forward. I'll be receiving your questions. Okay. There's quite a few. The first one is about GLP. So I'm guessing this goes to Dr. Arshni and anyone else who would like to add on. So are there any biomarkers which can be used to predict response to treatment to GLP therapy? And can we use these in patients who gain weight on antipsychotics safely?
Hello. So no biomarkers because everyone is eligible, and there is no definition of testing for something is when it's going to work or not work. This is the reason we have different GLPs, because when one GLP doesn't work, then you switch on to the next one. I'll elaborate a little bit more. We have GLP-1 inhibitors, we have GLP-1 and GIP inhibitors, and we have GLP-1, GIP, and GCGR inhibitors. So in events where one doesn't work on your patients, you move on to the next one. It's just like more layman, first line, second line, third line treatment. And we do tests. We test for a lot of things, specifically blood tests, only just to understand levels of inflammation in the body, what kidney functions are like, liver functions are like, just so that also because, as I mentioned, a lot of stigma and a lot of misinformation that GLPs cause long-term adverse side effects, which is not true. So my research has gone beyond just offering it as a treatment, but being able to prove that it does not cause any harm in the body or no long-term adverse effects, so to say. And sorry, your next question was?
Can we use this in patients who gain weight on antipsychotics safely?
Yes, absolutely. Only because, again, there's no barrier between or there's no interaction also, so to say. Maybe weight loss will be a bit slower because of higher inflammation, but this is something that we counsel our patients, of course, after getting medical history, and then telling them that this is the pathway of how the weight loss can be because you're on other medications. So yes.
I would like to add on that. From the clinical setting, I think when we're managing patients, because metabolic is one of the biggest risk factors that we are fighting. Locally, what we do and what has been given in guidelines that you can do in terms of prevention. For those who are practicing, you can actually check for your BMI for the patient, and you can also check on HbA1c to look at the glucose indices level. And especially when you find a patient who's borderline and is looking like at a risk of developing diabetes, or they are already obese, you can also add on glucophage to their management to support in terms of care. And most of the time you find that they don't progress into developing diabetes. Thank you.
There's actually a related question to that. Do these GLP-1 analogs, for those on GLP-1 analogs, do they need to be on them for a lifetime?
So a lot of recent advancement in terms of, yes, we have declared that you can be on these lifelong. Because remember, we said, as I was making my speech, it's something that's more mental. And often so, we don't have satiety. When we don't have satiety, food becomes comfort. And so a lot of us, even in our professions as doctors, we have sedentary lifestyles. So the declaration was that as long as you're microdosing and as long as you phased it out in the right way, it's only helping you manage. So you may not be continuing to lose weight and become skinny, but you're just helping yourself to be at that state where you can just maintain the weight. So yes, you can take it lifelong.
The next question is on dementia and the finger RCT study. Please share the details of the multi-domain intervention.
Yeah, so I think they focused on most of the risk factors that I've highlighted there. So starting with the lifestyle changes, so that includes weight loss, that includes physical exercise, and that also includes issues to do with dieting, especially encouraging people maybe to use a diet that is Mediterranean in nature so that they can be able to lose weight. But also issues to do with the reduction of cardiovascular risk, and that's in particular to hypertension management, and includes even preventative strategies like the use of statins. So in short, that is a very complex intervention, and what is most important is you are not interested in what aspect of that is going to work, but rather on the desirable outcome. And from that particular study, there was actually a very significant benefit in administering that multi-component intervention. I think going forward, perhaps maybe that is going to be the way to go. So we've just heard about the weight management from her, and then I think if we can also add other aspects of it and then evaluate it later on, we can actually see if it's going to have an additive benefit. Thank you.
Okay. Still on dementia, when a patient walks in with mild cognitive symptoms, is there any predictive blood tests we can recommend?
I think I'll just go back to what I presented on the ones that have been found to be very useful. So that I mentioned about the amyloid and also the tau protein. So I think those ones are doing very well at the moment, because there is even an established pattern. So if you find the amyloid to be depleted or decreased in the CSF, cerebrospinal fluid, then you may be able to say what kind of dementia they are going to have. In fact, in most of the instances, it will point to Alzheimer's disease. But also the tau proteins, I think those are the ones that I would prioritize. There are also others that I mentioned there, which are not very specific in nature, especially the S100, so which is associated mostly with inflammation. And in the morning, we were told that some of the mental health problems are usually inflammation in nature. But it could also be pointing to perhaps maybe somebody coming to the hospital, but also having other infectious conditions that can result in elevation of those biomarkers. So we don't really need to use them in isolation. I think that's going to be my message. So use of the biomarkers at the moment needs to be complemented with the clinical history, but also with the other neuroimaging biomarkers that we've mentioned. But if you just use them in isolation, it may be misleading because it could be a marker perhaps maybe of an infection that could cause. The good thing is if you detect it early, because the question mentions about mild impairment, if you detect it very early on, you may even be able to predict the future risk of developing dementia in case maybe the presentation as at that particular time does not meet the threshold.
All right. A couple of questions on neurostimulation, VNS. Are there cases of successfully treating post-traumatic stress disorder with VNS?
Yes, I think because VNS mostly modulates stress reaction through the modulation, it modulates the hypothalamus pituitary axis to reduce stress reaction. And I said it switches response to stress from that of sympathetic response to that of parasympathetic response. So from fight or flight, which is stress, to rest and digest, which is parasympathetic, which is a relaxed and less stressful state. Then I think it can be successfully used for PTSD and other stress disorders as described in the textbooks.
Thank you. When it comes to DBS, how successful is DBS in treatment of Alzheimer's?
So DBS can be used to treat Alzheimer's through stimulation of the hippocampus, the hippocampal phonics. So as the presentation said, there is memory formation, memory processing, and memory storage. So when you stimulate that area, it helps the brain perform those functions better. So it can be used to relieve the symptoms of Alzheimer's disease in that sense, or other causes of dementia. As the previous presenter said, Alzheimer's disease might be the biggest cause of dementia, but it's not the only cause. Also at the same time, we also borrowing from his presentation, we have to note that Alzheimer's disease is a progressive disease and cannot be reversed. So even those stimulations, those neural stimulations performed by DBS will only help to relieve symptoms and to slow disease progression, but it will not reverse the disease.
Okay. There's another question on neuroimaging and a bit of socioeconomics. Are there PET and SPECT scans for psychiatry covered by SHA?
I believe people who work in big hospitals like Aga Khan and Chiromo can answer that question.
Do we have anyone with an answer? Actually,
I can't say it covers, but I think we have a PET scan in Aga Khan, and I believe there is a contributory part. It covers a very low percent. So most of the people have to actually pay, and I think it's about 70,000 based on one of my clients who actually did. I'm not sure if it's the current price, but it's definitely very expensive. Neuroimaging, the cost impact is what is the prohibitive part. Even when you have patients and you want them to go to a functional MRI, which they can get in general accident house, majority of them will not come back with it because they can't afford. So you end up managing patients based on their symptoms, but sometimes even if you know what to investigate, that affordability part becomes a limitation.
okay. So those in government, I hope you hear the cry. A few more questions. One on dementia care. Dementia care burden weighs heavily on the young population. Could you comment on this? And can care for aging population impact mental health among the young? And should we address this intergenerational concern?
Yeah, so that's very true indeed. And so obviously it's the young people that take care of the elderly people. And I think we were told in the morning that for several reasons, including even the economic benefits, we need to take care of them, but I think also blessings that come with that because we are Africans. But sometimes that's not what we see because, you know, the young people are also facing quite a lot of economic challenges. So they are sometimes in school or perhaps they are working and then they don't have resources and then these people are abandoned. So we need sort of like a mind shift, especially with awareness, because there is a double problem there, not only living with the dementia, but also the stigma associated with the disease and the stigma also associated with being elderly. So I used to work in a setup where if you are blessed, you know, to grow old and then you have white hair, they'll probably think that you've perfected the art of bewitching, and then they would always attack those people, and that the government was working very hard. So you can imagine actually an elderly person being ostracized, while at the same time they are also facing the risk of dementia. So I think we really need to create a lot of awareness, and like I emphasized, developing dementia at the age of 70 could be related maybe to something that you did all happened to you when you are youthful. So it doesn't mean that you are immune. It's just to let people also know. So when you are doing education and also investing in education attainment, you also need to let the youth people know that actually it's going to lead to the reduction in dementia risk, and that indirectly is going to make them have a positive attitude towards the elderly people living with dementia.
Perhaps Dr. Kemonto, you could comment on the impact of caring for an aging population among the youth.
It's interesting because just yesterday a young man came to my office. I think he's actually a patient of one of the doctors here, and the mother has been my patient from last year. And initially, we diagnosed her with vascular dementia, but of course, most people don't trust Kenyan doctors. They feel like you are giving that, you're lying. And apparently, because she works for one of these big organizations, they did take her in February last month to South Africa, who also confirmed the patient has vascular dementia. But between last year and now, they did not take the treatment because this lady is single, has 2 children, and both have medical conditions and actually being managed in this hospital. So the level of preparedness was 0. Financial preparedness, 0. They are in the generation where if you give them a job, they don't sustain it. Financial management is poor. So they were not prepared for the long-term impact of their mom's condition where she's fully dependent on them. So it so happens that in between this 1 year, the degeneration and the progression of the dementia has reached a point where she needs full-time support. And even the treatment given, to be honest, may not actually respond or do anything. And what I saw and what I'm worried about is that we are going to have a house that is having 3 people who are actually patients, and I do not know who will take care of them. So definitely I think the youth are not prepared. They have no awareness. There's no psychoeducation for them to understand that their parents will one day not take care of them, and they need to be prepared to take care of them. And that means investing in their education, in their financial muscle, and their ability to support this generation. So we are going to have a very big crisis.
Thank you. I have a couple of sticky notes I've given you with the questions. Dr. Ashney, perhaps you could go first.
So I have a question. Patients on GLP have reported reduction in other behavior or addictive behaviors like gambling, alcohol use. Is that been your experience in the clinic? Yes, absolutely. So we do see that a lot of my patients definitely say they've reduced on the drinking, they've reduced on other addictions as well. And I think that just comes from that fact that there is satiety. And so satiety is for everything. And yes, lots of behavioral changes. There are depressive symptoms associated with GLP-1s, mainly suicidality, mood flatness, etc. Kindly shed some light. Do you screen for depression at any point in treatment? No, I don't. I refer because that's best practice. And so I'll always tell patients where to go just so that they can get that added support. And I get the confirmation from that doctor that they are okay to put their patients on GLP-1. So it's treatment that we do together. And seeing depressive symptoms, no. I think all these symptoms are more weight-related anyway. So the bigger patients have it more, and when they start losing weight, the biggest thing that we see in our patients is them gaining back their self-confidence, which now allows to reduce all the other depressive symptoms. How do these GLPs compare with Orlistat? No personal experience. I've actually not done so much research on Orlistat. I've always heard of it as a weight loss drug. But I think just basic light that I don't think it helps patients feel full, but also it's more oral than injectable. So again, bioavailability, and that would be my first biggest question. So lastly, are there some particular characteristics of patients you've recognized in your practice in regards to types of GLP treatments? No. Weight has become such a chronic problem for everyone. And I think the biggest characteristic is just lifestyle, just all of us having an absurd lifestyle. And so it starts with us as practitioners, but then of course we have majority of patients. Thank you.
All right, I'll go to Dr. Simon.
Yeah, so the question was, what is your take on the value of cerebroproteins in long-term prevention or management of dementia progression? And I'll look at it first from the point where we've said, if you can actually detect it early on before dementia develops, all Alzheimer's, then you get an opportunity to develop some predictive models, and in the process you and in other variables, which could be age, which could be lifestyle, and other risk factors, just to see what variability or to what percentages of prediction the proteins can be able to do jointly with the others, because I said you must not take them singly, but also in combination with others. But it is not only in prediction of dementia, but also in prediction of other complications, for instance, the behavioral manifestations, but also prediction on the effectiveness of interventions. Because every time we do clinical trials, there is always an objective on what are the correlates of this intervention working. So if we can actually use these biomarkers to predict that, I think it will be very useful, because you can tell early on which intervention is going to work and which one is not going to work. And I think finally, is in risk stratification. So in terms of the levels, you may be able to group people into those who are at high risk and those who are at low risk. And sometimes when these proteins are present in the CSF, in the cerebrospinal fluid, and also in blood, they usually affect the pharmacokinetics of medication that we are using. And we mentioned we are using a number of medication. Somebody might be on some antipsychotropic medication, and because of the presence of these biomarkers, the response to this treatment may not be optimal. Unfortunately, that has actually not been investigated. Thank you.
Thank you.
So the question that was written to me is, how cost effective is DBS, and where can we get it locally? So on the first question, it is not cost effective, so it is expensive, considering when I was in Brown University or affiliated hospitals, DBS used to be done as a procedure there, and it needs a multidisciplinary approach, which includes either a neurologist or a psychiatrist, as well as a neurosurgeon, and it is a neurosurgical procedure whereby they have to insert those electrodes to your brain, and also the equipment itself is expensive to buy. So the cost usually went in excess of $10,000, which is in excess of 1.3 million shillings, Kenya shillings. So I don't think it is cost effective. So on whether it is available locally, I can't say for sure that it is not available locally, but I doubt if it is available. some because after all, some of the hospitals that are coming that are innovative, like Chiromo Group hospitals, it could be innovative enough to have it. So I'm not sure about it. Maybe the people in this hospital can tell us. But recently, I saw SHA was offering sponsorship of treatment to countries abroad for procedures that are not available locally, but I did not see this procedure. So I think that is one thing that SHA can take up and sponsor people to be treated abroad for procedure as one of the procedures that is not available locally. So another thing is that it needs development in terms of expertise. As I've told you that a surgical procedure has to be done, so there has to be somebody to do the procedure. Also, equipments are needed, like the PET scans and the fMRI scans, and the people will interpret it and suggest which areas of the brain to be targeted. So you also need capacity development and equipment development also. And finally, I would say that the lowest hanging fruit among these treatment options is the VNS option. Number one, because it is older, so meaning there has been a lot of time to improve it and also to make it cheaper. And then number two, there is as I described during my presentation. So that is one of the neurostimulation stimulations that can be easily available locally to assist ECT, because ECT is doing the heavy weight lifting in our country. Thank you.
Thank you. I'm told we do have DBS and VNS locally available at Nairobi Neurocare Hospital. Dr. Horn has been part of multidisciplinary management of patients alongside a neurosurgeon who is doing very well. Okay.
So that means that is why SHA did not empanel it. So anyway, somebody's asking what is the cost.
I'm the one who was asking the cost, and I had another question before I answer what I've been given. We seem to be talking a lot about deep brain stimulation, vagus nerve stimulation, but nobody's talking about RTMS, and I'm wondering where was it left in terms of precision care, and how does it compare to the ones that you actually talked about, given that it's non-invasive, and actually we still have functional MRIs that can actually offer targeted stimulation to the brain activity, to the area where brain activity is not there.
Okay, so during the training, it was not covered, and that is why, because I was covering what we were taught when I went to that training. But as I was doing the presentation, I actually shared my presentation with another psychiatrist in Eldoret, where I work, and around that area. And she asked me the same question, and I replied the same answer that I've given to you. But now, in future, probably, I hope if I get another opportunity like this, maybe I can cover it.
I'm actually asking that question because there was a time Dr. Jengahan mentioned that he was going to bring the machine here, and we're very excited because definitely ECT, as much as it has been the old-fashioned, has been very beneficial, but it has its own risk exposures. And RTMS has even the portable form, and especially when we are doing maintenance for patients with chronic schizophrenia and those poorly responding to treatment. And it could have been something that bridges that gap. And in terms of portability, meaning that a patient can actually administer for themselves at home. The other aspect is, as I can hear my colleague talking about deep brain stimulation, by the time I convince my patient to actually agree to be open the brain and somebody places rods, if just taking medication is an issue, that will be something that we may not achieve sooner. And if I tell them that something else will be there that is just placed on the head, few minutes, and they're okay, they may buy into that. So we need to actually bridge that gap by bringing what is easily digested by the person we are going to be treating, while we are looking at the new precision modalities that may need longer training for that. And thank you. My patient actually benefited from it in India, and he's actually going back for another course. And there's been a lot of progress in his treatment for depression, which is treatment resistant. So my question, how can machine learning models be integrated into mental health care to support personalized treatment decisions without overwhelming the clinicians? This is a very good question because the Division of Mental Health, my boss is here, and there's a lot of work that has been done in terms of dashboards that are supporting this. So Dr. Prof. Atoli was able to talk about machine learning, and there's one aspect that he was able to mention, predictive analysis. So how do we incorporate this? When we go to the lower levels where we don't have psychiatrists, that is level 2 to level 4, we're seeing dashboards being made that are helping the community health workers, that are helping the nurses down there to be able to delineate in terms of symptomatology which patient needs to go forward and which one they can address. And you find that most of the dashboards that we have, and I think they already have the tools embedded in them. You find that it has the PHQ-9, it has the Mini for schizophrenia, it has the BDI. So they're able to, by the time the patient is just giving the history, it has already translated for you if there is a risk, if the patient has depression, what level, and what you should do. So it means that for those who interact with majority of the patients, they're able to sieve and be able to know this one I can refer to a psychologist, this one I can refer to a psychiatrist. But you see, it's an end-to-end system. And in this dashboard, by the time the patient comes to see a psychiatrist and is given treatment, again, we are able to manage the patient in terms of better outcomes. You can predict which treatment will work better, even including the genetic history, what family history they have. Because you find that if a patient was on sertraline and the mother was on sertraline, you'd rather give sertraline to this patient who has a mother who had sertraline and responded well, rather than giving fluoxetine. So that is the kind of outcomes that we are looking at, which are real time. Also, you can be able to know who is falling out of care, who do we need to follow, what other predictive symptoms do we have in terms of risk, who is at risk of getting depression, who is at risk of getting suicide. So these dashboards have been there, and I'm pleased to say we have one in the community level. And even in the tertiary setting, even here, we have a dashboard that is able to help us in management. In fact, you can be able to analyze outcomes of things from that kind of data that if it was analog, you'd not be able to do so. So for me, I would say it's already happening. Machine learning is already helping us. It's making it easy. It's making it reachable. And even the management of care is very precise and targeted to the patient, not just when we usually say you manage a patient just like a cover, the same way we were using the DSM-5, but this time you're managing a patient who you're seeing there, seated there with the outcomes that they have. Thank you.
All right. Thank you so much. Dr. Ashney has a question.
I have a question for all of you. I want to leave today just making a small comment or leave you with a question. And this is coming from the aspect of doing a lot of research on regenerative medicine and peptides, because the GLPs are peptides. Have you ever thought of incorporating peptides in your practice? And is that something that we want to advance ourselves in? Is that something we want to grow towards? As rightly said by my panelists, some of these procedures or some of the patients don't want invasive procedures. Affordability is the second question. So this is coming from an aspect of being a pharmaceutical company owner. How ready are we to advance ourselves? And just a small food for thought for all of you to go back home with. Yeah, thank you.
Thank you. So thank you to the panelists for championing that the ultimate goal is individualized, data-informed mental health care being the standard rather than exception. Could I have a round of applause and a photograph? A photo for the fan. Oh. As you come down, I have some.
Thank you very much for the wonderful mid-morning session. Welcome, Madam President, to our meeting, and thank you for gracing the occasion, Madam President. So we are now towards lunchtime, and I think I can use the symbol of lunchtime to explain how personalized mental health is the current emerging issue. I know there are carbohydrate lovers and meat lovers, and when you leave this place to go to the buffet, people will start with the carbohydrates, and because you can personalize your plate, you know you will have to reduce the amount of carbs you put as you wait for the meat ahead. So in equal measure, when it comes to psychiatric care, we have come to see even the amended Mental Health Act has the provision for us as the doctors to involve our patients in patient care and coming up with a treatment plan. So, and that is why this is a current emerging issue that we need to continue talking about now and in the future. Welcome to our lunch. Also some housekeeping. There are washrooms on 5th floor. We are currently on 6th floor, so just a floor below if you'd like to use them. And yes, enjoy your meal. I will see you at, you know the drill, at 1:29 for us to start at 1:30. Thank you.